So good morning, everyone. I first of all thank the organizing team for the wonderful invitation, and I am thankful for a good MDT team over here. So I'll just like to declare that I've not put evidences in my presentation, and these are just three small cases which we have managed at our own place. And a reason for not putting evidences is because these are rare case scenarios. Most often, the evidence which is available in literature is usually retrospective or case series or anecdotal experiences, or some are driven by some published consensus statements. So I think it'll be better to have a practical outlook into these topics. So I'll begin with my first case. So we have with us a 59 years lady, nursing staff by profession. Some time back, she was originally from Kerala, now settled in Varanasi. Had some history of subtotal hysterectomy. Uh, Improper details available, probably some oscillation done for some uterine leiomyoma, done way back in 2016. And then she says that she was diagnosed with some disease around the vaginal stump. Some vague USG reports are available with us around 2021, around 5 years later. But then COVID, and she did not get any particular treatment. She was not particularly symptomatic for any such thing. But then gradually she started having increasing abdominal discomfort, some problems in urination, increased frequency. And then she presented to us, I think, in 24 and mid 24. And when we examined, we could feel some vaguely defined abdominopelvic mass with restricted mobility, and the the rectal mucosa on per rectal examination was smooth, and there was no mass felt in the vaginal cavity. So I'll just run through the MRI, and we, there was no distant metastasis on CCT, thorax, abdomen, and pelvis. This is the MR imaging, the coronal section. This is the sagittal section. There's some mass seen in the pelvis, probably some large cystic spaces as well. I would like a radiologist to please comment on this.
Yeah, okay, so we can see this huge solid as well as a cystic mass which is filling up the whole of the pelvis. And can you just move the next one? So we can see that the cystic component is very bright on T2 while the solid component has a mixed hypo and hyperintense T2 areas. I cannot see the ovaries separately. She is a 59-year-old lady, and I don't know whether the ovaries were removed at that time or not.
We don't have those details, yeah.
Yeah, so all I can see is that this mass which is attached to the vaginal stump, and it is quite heterogeneous in signal intensity, and since previously it was a leiomyoma, so my thoughts will be on probably a recurrence with a leiomyosarcoma, probably because we have some history of morcellation also. And if you look at the axial sections, we can see that there are some adhesions along the anterior abdominal wall, and also this mass is abutting the rectum posteriorly, a long segment abutment of the rectum almost up to sigmoid colon, and anteriorly it is abutting the urinary bladder, although I can see the muscular layer of both the rectum and bladder well maintained. There is no mucosal nodules, so probably there is some abutment more along the rectum because it is a long segment involvement. And on the right side, the lesion is abutting the right external and internal iliac vessels, and the ureters are running along the posterior aspect on both sides, but there is no hydroureter. And I can see some lymph nodes in the pelvis, although small in size. So I am not very sure about how much the rectum is involved. At least there is no mucosal involvement. Even the muscle layer is intact. And on the right side, there is involvement, probably the ureter is very closely involved, and the external and internal iliac vessels. The pelvic side walls, the muscles at least, I think, were clear on both sides.
So, very well described, ma'am. So, these were exactly what the findings were, and it was a difficult mass in the pelvis baseline. There was anterior and posterior abutment with a rectum and a urinary bladder, and probably some focal abutment with the near the region of trigone was reported without any frank invasion. And So the next thing was we went ahead and did a biopsy and image guided, and the biopsy showed leiomyosarcoma, and the ICs were suggestive of it. So, so questions to the MDT surgeons. Um, do you need any other investigations?
If this is a leiomyosarcoma, I would always assess the lung and the upper abdomen at least. So a CT thorax.
So a CCT was done, ma'am, and there was no distant metastasis reported. Nothing in the lung, abdomen was all complete clear.
Then upfront surgery.
Any particular concerns with surgery? What would go in our mind? What consents? What preparations?
So as she very rightly described, it's very close to the ureter. I would probably either stent or either a DJ stent or a ureteric stent to intraoperative. Take definitely consent for a rectal dissection and prepare the patient accordingly. A CT scan assessing evidence of any other deposits in the abdomen other than the pelvis is very, very important, because even accordingly that kind of consent will have to be taken of multivisceral dissection if required intraoperatively. And apart from that, I don't see that we can give any kind of neoadjuvant treatment in terms of chemotherapy. If we feel that it is going to be possible for us to achieve an R0 resection, considering all these possibilities of visceral resection, probably surgery would be the best way to go.
All right. Any thoughts on requirement of possible exenteration here, removal of bladder? Would that be explained? Should that be explained to the patient at this time point?
Definitely, surgery to the urinary tract should be mentioned. At least a high possibility of a ureteric stenting plus minus reimplant, either unilateral, bilateral, depending on the case. And patient should be told that this could end up with a radical cystectomy, ileal diversion in the rare situation. And possibly if we are in high doubt, maybe a EUA cystoscopy would reveal a lot of information in order to counsel the patient about what are the chances of a permanent urinary diversion if the MRI is doubtful or the physical examination is not very conclusive. Maybe a preoperative, an EUA would be better to
This would be on a separate occasion than the planned surgery. Right. Medical oncology, thoughts on seeing this?
Yeah, so let me introduce myself. Yeah, I just jumped on the stage. My name is Dr. Sachin Trivedi. I'm Director of Medical Oncology at SCG Bombay. So, like my colleague said, our main objective of offering systemic therapy upfront is to assist and help the surgeons, okay? However, having said that, in this case, the Ki-67 ring seems to be pretty high. It's about 30 to 40%, like you said. So currently what we are doing, if you want to walk the extra mile, one is to look if there are any trials, clinical trials going on. Second is trying to identify if you can do some CTC and NGS beforehand, because once if you know what it is, if there is a systemic disease, then you might have to think in terms of adjuvant setting also. Also, my question is, if I am able to shrink the tumor, can exenteration be avoided? That would be my question to the tumor board. And in that case, we will revisit. Otherwise, if you think the surgical outcome is not going to change, then we will go for surgery.
So looking at the MRI plates, interior exenteration or even a radical cystectomy didn't seem a possibility in this case. Ureter was compressed. So, I would do a ureteric catheter just to identify the ureter, because these are highly irregular masses. But posterior exenteration, if there is no other disease elsewhere, as far as I know, limited knowledge about medical oncology in leiomyosarcoma, but we know that they usually do not respond to chemotherapy, and we don't want the disease to progress and then end up having exenterations.
Yeah, I agree, but medical oncologists are very infamous. The moment we see a patient, we are actually thinking. But like I said, if you get NGS, if you find rare mutational markers, if you find very high, PDL1 or TMB, In those cases, it's like I said, if it does not help you in getting a better surgery, then I wouldn't. But that would be a discussion at the tumor board.
So yeah, precisely these are the doubts when offering a possibility of exenteration to such patients with rare diseases. Not much of evidence available. Probably in today's date, we may not have a lot of systemic therapy options as well, at least the traditional ones. And how to go about it and how to counsel patients? Do we have anything to downsize it, or do we go ahead? So that was the dilemma here as well. Lucky for us that the patient was very educated. She herself was a nursing staff, and we could talk about everything, all the possibilities with her in a very open discussion, and she was very receptive, and she agreed to the consent of exenteration, and we actually, as discussed by the panel, we did a cystoscopy beforehand, and there was mucosa was stretched over the trigone of bladder, so but no intravesical component, and so we were more probably thinking on lines of exenteration and anterior exenteration. PET scan was done, no distant metastasis was seen, and we decided we'll go ahead with surgery, having explained everything. And we did do a preoperative DG stenting. Our thought after the MDT discussion at our place was we would plan for neoadjuvant if the patient had not been consenting for exenteration, which was not the case. So, and we did laparotomy. We began with surgery. However, to our surprise, we found 2 peritoneal nodules. We sent them for frozen section analysis, and it was reported as atypical cells. We again went into dilemma. Now what to do? Should we actually go ahead and offer surgery, which may, and on the field, tumor was, as rightly reported by ma'am, was seemingly extending to the right lateral wall near the external iliac vessels. On the first look at it, possibly it would have been inoperable, may not, would it be resectable, didn't know. So the team decided to abandon the exploration and not do much, and wait for the final histopathology, spoke with the family, and didn't disturb much, and surgery was abandoned. The final histopathology did not, of those peritoneal nodules, did not reveal any malignancy. So we rediscussed the case in our MDT discussion, and we thought we'll go ahead with curative intent. However, because the disease was a little extensive and we had already opened her once, we thought let us try and see something if we can offer her. And after our MDT discussion, our medical oncologist decided to go ahead and offer a doublet chemotherapy. And so, sir, what is your experience in sarcomas with chemotherapy in general, visceral sarcomas? What do you think?
So, like Madam was saying, unfortunately, it is not one of those very chemosensitive type of disease. Having said that, certain characteristics do indicate that some treatment might respond, the patient might respond to some of the treatment, especially this Ki67.
Correct.
So fast
that was
dividing.
Something which inclined us as well. Yeah.
So that means that their chances of responding are pretty high. Also, those response rate assessment based on histopathology comes from historical data when we were not routinely doing Ki67 for certain types of tumor. It is a very interesting that you have used the combination of gem-docetaxel. That is also my preferred choice. Having said that, if you look at the evidence, people are actually advocating single-agent doxorubicin. I would have gone with gem-docetaxel. But like I said, if money was not a problem, we would always do a comprehensive genomic profile, do a PDL, because these patients we know we are not going to be able to cure just by chemotherapy. We will have to think of either surgery and also what happens next. So rare diseases like this is like a game of chess. You have to think two steps in advance.
Correct. So, the patient was reassessed after 4 cycles of gemcitabine and docetaxel. Clinical response was very good. Actually, I forgot to mention that because of her increasing compressive urinary symptoms, she did require Foley's catheterization. And however, soon after her chemotherapy was started, probably I think 2 cycles into it, the catheter was removed, she was visibly feeling better. Some component of pain was gone, and otherwise she is a working active lady. And so we have the post chemotherapy MRI here, and I would like the team to see it, and then the radiologist probably to comment on it.
Yeah, so I cannot see any significant change in the size of the lesion or even the characteristics of the lesions. It still looks ill-defined and the size is same, so there is hardly any response imaging-wise here.
So we felt that there was probably some decrease in the solid component, which was more anterior near the bladder. But yeah, more or less we would agree that there was not significant response, though there was good clinical response. More chemo, surgery. All right. So we did go ahead and perform surgery, and we were prepared for everything. And clinically, it looked better. And we did begin with EUA, and this time we felt that probably compared to the previous, because the surgical team was same, compared to previous time, the field was better, and we decided we'll go ahead and do whatever is required because we had all the consents taken. Patient underwent surgery. She actually required supraelevator posterior exenteration. As ma'am said, the ureters were compressed. The DJ stenting helped us a lot, especially on the right side, and we could do an en-bloc excision of the mass with a low anterior resection with a colorectal anastomosis with diversion ileostomy. It was an R0 surgery, though there were cystic masses there at places. There was no specimen perforation. I think I have a short video of it. Probably this was the specimen. We can see the rectum attached, and the specimen was all the integrity was maintained, and there was no perforation. So this is what we were hoping for, and the report again said the same thing. The vaginal margin and the rectal margins were free. There was no frank invasion. There was just abutment in sync with our preoperative radiology. And what next? More chemotherapy, more radiation. Do we have a radiation oncologist
in-house? So my question is, did we ever consider doing a PET scan?
We did. We had done at baseline, sir.
And baseline and post chemo, was there any difference in the?
We did not do a PET scan post chemo. We just did it at baseline, and prior to surgery again, at time of response assessment, we did a CT scan, and there was no obvious metastasis.
Okay.
We did not see any metabolic response.
No, but post surgery, post chemo, you did not do a PET scan.
We didn't do a PET scan.
Yeah. See, there are large areas of necrosis being seen.
Absolutely.
So now the question is, was it already there, or was it a response to chemotherapy? We don't know.
So would the radiology provide us an insight into it, the MRI?
So at the time of the first MRI, also there was necrosis, and after the chemotherapy scan also there were areas of necrosis.
Visibly, there was a large cystic space, spaces.
So that cystic space probably had more of hemorrhage rather than necrosis because it was T1 bright. So I guess that it had more of hemorrhage, the cystic component. The solid component had some central areas of heterogeneity. Maybe it was necrosis in the solid component, but I did not see a change in the character of the solid component post chemotherapy.
So, opinion of the house, any adjuvant radiation therapy, is it required in such a case? Would we offer something or not?
So this is kind of an evidence-free zone, and we will never be able to have a consensus on this. But we will always have a consensus on one thing, which is to do the best for the patient. In absence of knowing whether the patient has responded to chemotherapy or not, it is very difficult for me to recommend the same regime. If we had done a CTC baseline and then CTC post chemo, or a PET baseline, PET post chemo.
Sir, what are your thoughts on the use of CTCs in clinical management in the current times, especially for sarcomas?
I agree. See,
Just given that it is a rare case.
It is a rare tumor, but the fact is, sarcomas metastasize to lung.
Yeah.
They will go through hematogenous route. And the second thing, there is low sensitivity but high specificity. Finding it helps you, not finding it does not help you. That's my take. Okay, and that's why I say, in certain cases, it is very difficult to generate evidence. And in fact, I'm working on an article about how are we going to run randomized controlled trials when we know that every tumor is different. So we have to sometimes think out of the box for rare tumors, not for all the tumors. But in absence of that, I will not be able to recommend. But if I had high patient with high CTC burden to begin with, SUV very high before chemo, it gone down after chemo, even your team thought that there was some response, then I may have offered, but in absence of that, maybe give patient a choice. With regards to radiation, I think radiation oncologists are not very keen to put radiotherapy in this area.
Correct. So this discussion in our MDT was also on similar lines. However, we did think of discussing it openly with the patient. The option of post-operative radiotherapy and its attendant morbidity profile was discussed. Patient was not very keen and she deferred any further treatment and she underwent stroma closure. She currently continues to be disease-free at 6 months. So let's see. So we now move on to the second case. I think So we have with us a 35 years lady presenting with abdominal lump of 3 months duration, no history of any prior surgery. She had a kid and family was still incomplete. She was wishing for further family planning, and on clinical examination there was a mobile abdominopelvic mass, and it could be felt similarly on bimanual examination. I'll just go through the CT scan. The radiologist comment.
Can I see the sagittal?
Yeah.
joint? Okay, so there is again this huge solid cum cystic mass that is almost in the midline and also extending to both the right and left sides, and I can see that it is attached to the uterine fundus and probably extending into the myometrium. The endometrium seems away from the lesion. It seems smooth in outline, and I could not make out really where the ovaries were. Probably they were pushed down by the tumor, and I could see a right ovary probably separately. The left I wasn't sure about, and considering the age of the patient and the fact that it was the epicenter of the mass was in the uterus rather than the ovaries, but still I am confused about the left ovary. So firstly I would think in terms of a uterine sarcoma, some of the variants like the embryonal sarcoma or even the mixed malignant Mullerian tumors which have the similar appearance. We can see a bunch of grape kind of appearance and a lace-like enhancement which is described in embryonal sarcomas, but still I think I would not be able to very confidently say that it does not have an ovarian origin or an ovarian component. But again, if you think of serous tumors of such big size, they will probably would have already metastasized to the peritoneum, and there would have been peritoneal metastasis and ascites. So as a radiologist, the biggest challenge is to recognize the tumor of origin, because once you're sure of that, it solves half your problems. Because rest you can guess on the basis of the imaging features and the age of the patient, and if you have the hormonal profile or any tumor markers. So because it has a very typical appearance of an embryonal sarcoma, I would think of a uterine origin and a uterine sarcoma.
Right. So that is what it was reported as, and the case came to our MDT. Surgeons, what do you opine? Would you want to do a preoperative biopsy, or would you?
All the
So
tumor,
the tumor markers
markers,
were all non-contributory.
all
Everything was non-contributory.
including the germ cell ones.
Yes, yes, everything was non-contributory.
Okay.
We did everything. I'm sorry I did not add it, but yeah. Would you want to biopsy?
35 years, such a massive tumor, we don't know. a biopsy would be in place.
All right.
There were no fat components in the tumor.
There was no?
If we think of germ cell tumor, there was no fat, no calcification. Yeah, in this age group, we can think of something like probably some rare epithelial cancers like a
Would
clear
you,
cell or
uh,
endometrioid.
Would you not put this as a possibility of mucinous tumor?
Ma'am,
And
it doesn't show the density of mucin.
difference?
Yeah, and plus a mucinous cyst adenoma or even a carcinoma does not show so many septations. Like it is almost, it has a honeycomb-like appearance. It is, and those septa are enhancing. In mucinous cyst adenomas, there is no septa, but a multiloculated appearance with different densities of mucin. So it was, the density was not indicative of mucin.
So the biopsy was done, image guided, and it showed an endometrial stromal sarcoma, low grade. She was definitely planned for surgery after MDT discussion, but the patient continued to be very insistent on fertility preservation. Thoughts of MDT? Any chance can we offer anything to her in such a case? What was reported was that the ovaries were normal and the mass was arising from the uterine fundus. It was a biggish mass and stromal sarcoma, albeit low grade.
Low-grade ESSs are usually hormonally sensitive. They generally have good prognosis. So rather than upfront saying cannot be offered, I think the approach should be, if possible, we will offer. But it all depends on your intraoperative findings.
So, what finding are we looking at, or how do we think before going inside? How do you think we would want to?
So one
try
thing
and
is
do
that
it?
these tumors are extremely vascular and they do tend to form a lot of peritoneal deposits. So a thorough exploration is very, very warranted. If you are able to get away with an R0 resection at all sites, even assessing the uterine fundus, everything, yes, because she's so insistent, and then you can, in the post-operative period, keep her on a duration of hormonal suppression. But to say that for a low-grade endometrial sarcoma, not to offer an option of fertility preservation.
So, what would you offer in the form of fertility preservation? How would you counsel the patient? What would you do?
So yes, see there have, so of course recurrences, of course the probability of conversion of low grade to high grade, which is also seen, and if it, and a very, very close follow up. If it does happen, then at that point of time think of what do you say, a radical surgery. Right now, basically removing the mass and any other site of disease with the understanding that the uterus is free and the mass is not completely involving the uterus. It is possible to preserve the uterus. If it is not possible to preserve the uterus, then other options of fertility have to be discussed. All these things have to be discussed with the patient.
So, she was a young lady, and all these possibilities were discussed. Medical oncology, any inputs, any neoadjuvant hormonal treatment, anything else for such a case?
So just going back to the fertility preservation, egg preservation, ovarian tissue preservation, followed by intraoperative stuff. ESS will respond to endocrine hormonal therapy. There are two markers, JAS and SUS, which needs to be done. That helps in prognostication, but also planning in cytotoxic chemotherapy if required. But no neoadjuvant. I wouldn't recommend.
So this is what was decided, and we did go ahead with surgery. What we found was the tumor was arising from a broad area on the uterine fundus. The ovaries were completely normal and separate and away. And so after a lot of deliberation, the gynec oncologist and us together, we decided to excise the mass en bloc with the hysterectomy. We did not consider saving part of the uterus viable, and bilateral salpingectomy was done, but ovaries were preserved. We thought we'll see what more can we do, and we had already explained everything to the patient in detail regarding possibility of recurrences, regarding final histopathology. So this is what we did. Surgery was uneventful and he recovered very early. This is the histopathology report. Endometrial stromal sarcoma, there were areas of high grade differentiation seen. It was estrogen receptor positive, progesterone receptor positive. What now? How do we talk to the patient? What do we tell her? Opinion from MDT, surgeons, medical
With
oncologists.
high grade, even the ovaries have to go. So, can't keep the ovaries in.
Can we try and keep it and offer adjuvant hormonal treatment and just keep it on very close surveillance? Patient is insisting on it. That's it.
It's a evidence-free zone, so I guess this has to be discussed in high detail with the patient. She has the child, she's 35,
Yes.
so definitely premenopausal.
Yes.
She has to understand the risk of keeping an ovary with a high-grade sarcoma in place.
Yes.
She has to be well counseled.
So these discussions were appropriately done, and she was advised on removal of ovaries. She did not want to undergo another surgery. Like many a times in such cases, it happens, and she was like, "We'll see what happens. We'll get an ultrasound done every month if you say, but please give me something, and we'll go ahead." So she was started on adjuvant hormonal treatment. However, 1 year later, nearly 1 year later, USG showed she was asymptomatic. USG showed complex solid cystic lesion in the left ovary, and no other site of disease on the CT scan. So patient was planned for resurgery, and no biopsy, nothing. Patient agreed that please go ahead and remove the ovaries. So we did go ahead and operate her and did the needful. The histopathology came out to be endometriosis. There was no malignancy in the ovaries. So weird case, and but yeah. So anything further on this case? Could we have done anything better?
I'm surprised, like after the uterus is gone, the hormones are gone. Why would this ovary have endometriosis unless and until it was already there?
Yeah, probably it was already there.
And then the
We did not know.
hormone treatment that was given
Probably flared
caused
up
it
or
to
something.
flare up.
Don't know. So this was a very rare thing for us and difficult, and it gets very difficult to talk to the patient and explain to the patient after having done 2 surgeries and such rare scenarios. And,
It's difficult to explain to the oncologist also, actually, not just yeah. So pathology is strange sometimes.
So quickly, I think we'll quickly go to the third and the last case. 46 years lady. She had undergone surgery outside in some peripheral non-oncological setup for some ovarian cystic lesion on the basis of an ultrasound report, and no baseline CT scan or any imaging was available. Probably some laparoscopic adnexectomy was done. The operative notes not very clear, but vague reports did say that no other disease noted and no rupture or spillage apparent as per the report at least. And the histopathology was low-grade serous ovarian cancer, and it was reviewed. The slides and blocks were reviewed, and it was again the same thing, low-grade serous ovarian cancer. This is the CT scan. What are we hoping to find here, or
The second CT scan was done for.
so this was just to restage because we did not have any CT scan done at baseline.
Okay.
She was from peripheral region, periphery. She had some ultrasound report based on which she had undergone an adnexectomy.
Okay.
There was no imaging available cross section.
So, what was the size of the tumor?
So I think some 6-7 centimeters, 6 or 7 centimeters, and
And did they put an incision to remove that?
there was a small incision. Very difficult to say retrospectively now that whether it was punctured, aspirated, was removed en bloc.
So
Very difficult.
the
Most
tall
likely
claim, the tall claim is always that we had ruptured it in the endo bag, which we don't want to believe.
Correct.
And this is a low grade serous, so complete staging surgery. She's not going to respond to chemo.
Correct. So we did a CT scan and we did not find any imaging. I just want to ask one thing, because probably as ma'am said, the same thing we also discussed, that there would have been some spillage for sure, and especially when the operative notes and everything is not so much clear. As a radiologist, or as we are evolving in the field of peritoneal surface malignancies, would you advise pre-operatively any peritoneal MRI or anything such in such a case beyond a regular CT scan?
Yes, definitely, because I cannot comment on the ovaries very confidently on this CT. Peritoneal disease, definitely we would need MRI, but even for the ovaries, I would be able to comment better on MRI, considering they look very small in size. And probably there was something on the right side also, on the right adnexal side also, I could see some soft tissue. And on the left side, it was a solid small lesion in the ovary, with slightly irregular borders. There were no cystic components, and apart from that, I could not see anything else. So probably an MRI would have helped in this case.
So she did go ahead. We did not do an MRI. I was just curious about it from the point of discussion. As discussed, we went ahead with a staging laparotomy and type 1 hysterectomy with opposite adnexectomy, and infracolicomantectomy was done for this case. If we did a staging laparoscopy and we did not find any disease, just a practical question, would we still, in this case, would we still want to go ahead and complete the staging procedure, or would you want and defer it, the surgeons?
Patient is 46 years old.
Correct.
We don't want to wait for a recurrence. And as she said, there's probably something in the on the left side, and there's something left behind on the right side. And laparoscopy, there's always a rupture.
So with the same mindset, we did go ahead and the surgery was done. To a surprise again, on the histopathology report, we found a very small size endometrial adenocarcinoma in the uterus, low risk molecular profile wise. And so what next? Further treatment, we put her on adjuvant hormonal treatment.
So we will put her on, but that staging, so that you said you found stage 1A, where was that lesion?
Correct. So
In the residual ovary, was it?
no, in the second ovary, yeah, endometrioid in
And
the
was,
ovary.
it is in the uterus. Okay.
The other ovary.
Okay.
In the first ovary, there was some
And
cysts
stage
or
1A,
something.
so we will not offer chemotherapy, but adjuvant hormonal therapy should be offered to the patient. I agree.
So that's the same what was offered at our place. So
Medical oncologists are like lawyers. You commit a crime, we always have something to get you out, but not completely out. See, there are newer studies, mTOR inhibitors, drugs like tremetinib. There are trials for endocrine therapy plus CDK4/6, but that we will leave for. The problem is the chances of recurrence are very high. But having said that, surgeons will cure it. Even if it comes back, you should go for surgery. But
all right. So I think I'll thank the panelists and the MDT for an excellent discussion.
questions.
Sir, yeah.